Good evening, ladies and gentlemen, and I welcome all of you to 79th AIOC 2021, the virtual conference. And I would take this privilege to invite Dr. Ashok Rangarajan. Sir, welcome once again. And now I would like to hand over the virtual dais to you, and the screen is all yours, sir.
Thank you. Thank you very much. And we have had an exhaustive 4 days of scientific session. But I'm as excited as I was at the start of this entire AIOC about this particular instruction course, because I have as my co-instructors some of the very tall figures in ophthalmology and cataract surgery in this country. One. Number two, this instruction course has been aimed at those cataract surgeons who have achieved some amount of proficiency in performing phacoemulsification and who have now their practice has expanded, that they are facing more challenging scenarios and wish to deliver well. So with my co-instructors, I hope to be able to give all of you phaco surgeons some very valuable tips in facing certain challenging situations as we have it. I will be talking about the brown, black, and white fake cataracts where we can do phaco. Today's technology and techniques have advanced so much that in all clinical scenarios, we're able to do phaco. Dr. Arup Chakravarti from Trivandrum will be talking about phaco and posterior polar cataract and special techniques which you need to do to protect the endothelium. As we know, there are two structures we are very worried about and wish to protect during phacoemulsification, that is the endothelium and the PC. We have Dr. Sagar Bhargav from Kolkata, who will be talking about phaco in small eyes and in post-RK eyes. Dr. Meenu Mathan, again from Thiruvananthapuram, will be talking about phaco in subluxated cataract and in small pupils. And then we have Dr. Sujata Mohan from Chennai, a very senior cornea and cataract surgeon, who will be talking about phaco in compromised endothelium and in certain complex clinical scenarios. So without much time spending, I'll start off with my talk. As I said, the color or the density or the hardness of the cataract is no reason to not do phaco today. To answer this question about how hard is hard, there is no specific classification available in literature. It is very relative. It's relative to your experience. It's relative to the ocular condition, the expectation of the patient, and what you feel you can deliver in your clinical or hospital or clinic or surgical scenario. So it's very important that as a phaco surgeon, you know your strengths, you know in which scenario you're operating. For example, if you're in an institution, you might have other seniors to come and help you. You should know when to bail out. So these are important factors. Next, very important thing is you must have a good preoperative ocular examination done. So if you're dealing with a compromised endothelium or pseudoexfoliation or senile meiosis, those might make the situation even more difficult than the cataract already is. So you might not want to do in those situations. The very important that we spend a lot of time in counseling the patients that they might need a second surgery, a bailout surgery, and so on, so that the patient understands the clinical scenario where we are delivering. Most of us do phacoemulsification today under topical anesthesia, but this is a difficult scenario, so you should not hesitate to give peribulbar. There is no ego here. The last point which I wish to make is what will be the approach? Should it be superior? Should it be temporal? Should it be corneoscleral tunnel or clear corneal? Is each individual's expertise and comfort zone. Personally, I do temporal clear corneal for all clinical scenarios. The next important thing is whether it is brown, black, or white, I stain all the capsules because one gives a good contrast, and not just for doing the capsular excess, but even afterwards while doing the vertical chop. I'll show you in my videos in the next slides. It shows a good contrast, so we are able to see the capsular edge almost at all points, and we can take care in not damaging the capsular edge. Very important use is the use of ocular viscoelastic. Most of us use methyl cellulose for routine phacos, but here I would use a thicker combination of chondroitin sulfate, sodium hyaluronate. The chondroitin sulfate coats the endothelium very well. The combination together maintains anterior chamber very well. Sodium hyaluronate alone would also probably be a good space occupying viscoelastic, but it will come out very easily, whereas a combination with chondroitin sulfate does not egress very easily. So it stays in the chamber and it coats the endothelium as we do the phaco. The other important thing is even in the middle of surgery, you could come out and refill, so that because there is no epinuclear bowel to protect, and this acts as a good buffer against the PC when we are doing the last few pieces of phacoemulsification. So very important is to choose the thing. Here I'm showing a video of the next important step, the next important step which I wanted to show is hydrodissection. So before I start the video, let me just explain to you that there are two aspects you must remember: that the chamber has already been pressurized with some heavy viscoelastics. So adding more fluid to it, you are increasing the intra chamber pressure. So one is that, so you must decompress the chamber. Number two is there is not much space between, as you can see here, between the rexes, because the nucleus is huge. So you must learn to decompress the nucleus center so that the fluid does not collect between the nucleus and the PCA and causes a PCA rupture. So as you can see here, the first thing is to decompress the anterior chamber a little bit so that there is an egress. And then you go right inside. There is no role of hydrodelineation here. It's only a hydrodissection. There you can see the slight rise in the nucleus as the fluid wave goes behind. And then you press the center to ensure that it's released and there is no trapped fluid within. The other thing you could do at this stage is you could put a Sinskey's hook and rotate the nucleus to confirm that you have achieved good hydrodissection, refill to coat the endothelium with chondroitin sulfate, and get ready to proceed with phacoemulsification. Here, again, a very dense, compact brown core presented as a white cataract in a 70-year-old diabetic. Diabetics usually have a thick posterior plate. I tend to do a crater or a wide, small tunnel to give me the space to do the vertical chop. I'll pause the video here because I wish to point out that I make the left-hand side entry close to 90 degrees away. That's because I'm comfortable that way. I put in the second instrument a little later because what I wish to point out is you could make the stab entry later after you have started the trenching. Some might want to do it very close to the main incision to have a, almost in the same axis as the phaco probe. And some might want to do it away. You could vary the second side instrument based on the ocular condition. In deep set eyes, you might find it very difficult to go full 90 degrees. So this is one point I wish to make. The second thing is I would use continuous mode here, lot of power. Impaling is very important. Keep the probe impaled and dig in with the vertical chopper. I use a vertical Rangarajan chopper, which has got a long tip and a sharp tip at the edge. So you chop all the way down and ensure that the posterior plate has separated. Normally, I would not remove the pieces, but go all around chopping. But in some situations, I eat off at least one small piece because it gives some more room for the nucleus to rotate. And you proceed in removing small segments of this and watch that we are doing it fairly deep because there is good chamber stability and we are not catching the top of the piece, but the bottom of the piece so that the endothelium is protected. And because there is adequate chamber stability, we can visualize that the PC is far away. We are in safe territory, doing all the emulsification in the center. And one needs to emulsify, only then the piece will go inside. Otherwise, there will be stagnation and the piece will not enter and get emulsified and the port will get clogged. At this point, I wish to just point out here that I use a Venturi system most of the times. Any of the systems today, it's not Venturi or peristaltic. One is not better than the other. You could change the settings to achieve equal performance. And here I would use a lot of burst mode for impaling the phaco probe. And I don't know if it's visible here, about 60 pulse per second is my hyper pulse mode while you chew the pieces away. Because by using pulse mode, I have seen that there is less chatter and good followability of the pieces as they go. And you can see here that both have got only 40 power. You don't need much power when you're chopping and you're using a high vacuum and pulse mode, hyper pulse mode to take the pieces away. Remember that there is a role of chopping and sub-chopping which you need to do to make the pieces smaller. And I wish to point out here that as I'm chopping, you can see that we are separating the central disc away. This central disc can be confidently emulsified because there is a lot of buffer behind it. And once this is taken away, it kind of breaks the back of the nucleus, as I call it, and the rest of the nucleus emulsification is fairly simple and straightforward. In the peristaltic kind of machines, I use 440 aspiration flow rate. The aspiration flow rate must match the vacuum, otherwise there will be a lot of turbulence in the anterior chamber. before you can get adequate and easy performance in these kind of cataract situations. So now I'll move on to certain video clips that I have of surgeons whom I have supervised, and certain small what not to do kind of situations I'm going to show. So again, white cataract with a compact dense core, and one must use high power so that there is no rocking of the nucleus, number one, and the trench which is made should be wide enough to accommodate the phacoprobe inside. As you can see, the surgeon is still skimming in the surface and rocking the nucleus, which might cause some zonular harm if this is continued. So you might need to either increase the power or make wider trenches so that the phacoprobe is able to sculpt through the dense core in the center. So important message here is do not rock the nucleus. Next thing here is very important in all these clinical scenarios is to not have or recognize the formation of cataract milk. Cataract milk is that emulsilate which forms, which is evidence that there is a heat generation happening because the outflow is not happening adequately. Here you will see as the surgeon is trying to chop, there is a little, there you go, you can just see that the little cataract milk came out. Persistence with the phaco power at this stage will cause probable wound burn to happen, especially in these kind of scenarios where we do clear corneal cataract surgery. Another situation where I want to show that in situ chopping must be done. Once you have impaled, you must chop at that point while the surgeon continues to pull back out of the fear. And you will see that the port gets blocked in the wound here. And then as they try to go back inside, they have caught the piece of iris there, the pupillary margin. And this in turn, with the persistence, has created an iridodialysis. And these kind of situations are disastrous. What the surgeon should have done once they had impaled is done the chopping procedure there itself in that position and not pulled back. Another thing I wish to show here is where the surgeon tends to, again, this is just that you need to be a little bold, little lack of confidence. So they tend to rotate the nucleus into the anterior chamber and attempt the chopping in the anterior chamber, thinking it's very safe. But Lord save the endothelium in this situation. So I just wish to share that whenever there is unstable anterior chamber, most of the situations today, we don't have unstable anterior chambers because we have these microflow tips and ABS systems. You could increase the bottle height and lower the vacuum. Similarly, sometimes the vacuum might be there, but there is no followability. In those situations, you might want to stop, refill with viscoelastic in the anterior chamber, irrigate the port so that the clogging of the phacoprobe has not happened, and then continue the procedure, making sure that you have not had a PC tear, because if there is vitreous strands in the anterior chamber, it's going to prevent the phacoemulsification from happening. And I think there, just to summarize now, do not hesitate to give peribulbar anesthesia. Do not hesitate to create a scleral tunnel. If you feel you might want to have a bailout option in hand, that's a wonderful bailout option. You could convert to an SICS and deliver the pieces out if they are not getting chopped or emulsified easily. Do stain the capsule, use heavy viscoelastic. These are the two probable things you should work towards: is do chopping, preferably a combination of vertical and horizontal chop. Do sub-chopping to have good results. Use hyperpulse and burst modes. And lastly, remember, there should be no ego, and at the same time, there should be no fear when we attempt any of these high-risk situations. You must also remember to take the help of your senior colleague should the need arise, even in the middle of the surgery. Thank you very much for your patient hearing. I think, though, I would just slightly change the format because Dr. Arup has another commitment also. Can I request you, Dr. Arup, to come forward with your presentation?
Yeah. Thank you.
Is Dr. Arup there?
Yes. Yeah.
Yeah. So Dr. Arup is the director of Chakrabarti Eye Care Center, and I can go on this all evening and all night talking about him. He's a dear friend of mine, a senior of mine. I still ask him for a lot of tips and tricks, and he has trained many people, a lot of presentations, a lot of papers, a lot of books. He's a chief instructor in many good courses in India, US, AP, ACRS, and the works. So I think all of us know about him. Let's not waste time talking about him, but see all those wonderful things that he has to show for us today. Over to you, Dr. Arup.
So, good evening, friends. This is Arup Chakrabarti. Thank you, Ashok, for the very kind introduction. Ashok actually has been a very, very good friend, and he is a very reasonable man. He's a good surgeon. He's rational, and many a time I ask him if I have any clarifications on a lot of issues pertaining to practice or case management. So he has asked me to talk on two topics. One is phaco in posterior polar cataract, and second one is something healthy habits for unhealthy endothelium. Okay, so let me start off with the first presentation. So, I have been doing post-polar cataract from the early 1990s, and at that time there was not much available in the literature. The techniques and strategies were just developing, so I sort of evolved. Now, over the last 27 years, and I have got my own strategy in place, and I've been using it for about 25 years with very good results. And the main challenge here is the occurrence of posterior capsular end. It may be pre-existing, we call it congenital posterior capsular dehiscence. It may occur during hydrodissection if you perform a cortical cleaving hydrodissection or an inadvertent cortical cleaving hydrodissection. Nucleus cracking, nucleus chopping, vacuuming of the posterior capsule, traumatic bagging of the trailing haptic of the intraocular lens. In fact, I have encountered PC rent in all these situations. And I have recently seen videos where it occurred during stromal hydration. I'm not sure whether those were cases associated with flax, where there's a trauma to the injury to the posterior capsule because of flax. I'm not very sure about it, but that is also one of the possibilities. So these are some of the cases. Clinically, they're not very difficult to diagnose. All of these patients had open posterior capsule. This is the spindle defect that you see, in addition to the holes that you see here. The white powdery deposits. There are oil droplets-like structures on the anterior vitreous. Tri-radiate extensions. All these patients actually had a posterior capsular end, and none of them had any vitreous disturbance. They already had a pre-existing PC rent. Now, in certain situations where you have a brunescent nucleus and these things may be concealed, all these posterior capsular polar findings. So, if you look at the fellow eye, you will see either it is aphakic or it is pseudophakic with a PC rent and vitreous intersection. So then you can assume that you're dealing with a challenging posterior polar cataract, and you need to evolve your strategy. See, over the years, there have been a lot of diagnostic imaging publications in the literature, high frequency ultrasound using 25 or 50 megahertz, Schim flag imaging, antecedent OCT, intraoperative OCT. And all these things are good. There have been very nice publications, brilliant publications, and very, very nice pictures. But if you are not using all these in your practice, please don't belittle yourself. Don't feel guilty that you're not delivering justice to the patients, because whenever you encounter a patient with posterior polar cataract, there is no discrimination. All posterior polar cataracts can lead on to PCRL. This should be our mantra, and devise a surgical strategy accordingly. So I have a separate strategy for soft posterior polar cataract, and different one for hard cataracts. So let me focus on hard cataracts today. So this particular gentleman is in the mid 60s, and this just shows the surgical technique. And the next one is one where I'm going to have a complication which was well managed, and patient did well eventually. So here, since hydrodissection has not been done, so I cannot rotate the nucleus. So I'm going for a direct chopping with the Chang chopper. So the nucleus is elevated slightly, and then the chopping is carried out. Here the game plan is on the nasal side. I want to chisel out a big chunk, wedge-shaped chunk of the nucleus from the parent body of the nucleus, thereby creating space in the central and the inferior and the nasal capsular bag. All this lateral separation that is happening is at a more anterior plane in the capsular bag, so there is no transmitted force going across the posterior capsule. Since I should not be rotating the nucleus, so I just tilt the phaco handpiece, and I get an appropriate, almost 4 or 5 clock hours here, appropriate chop, and then I have a big chunk of the nucleus which is emulsified, and then we thereby I have more space. You'll be seeing in the central and the nasal part of the capsular bag. Then again, I tilt my phaco handpiece. It brings the rest of the subincisional nucleus in a more accessible, the deeper aspect of the central of the anterior chamber. You have to use a lot of cohesive, dispersive OVD to protect the corneal endothelium. It goes without saying. not only because it's a hard cataract, but because you're performing manipulations at an anterior plane. So everything goes up pretty well, and patient had done well. But now this is the case that I wanted you to see. This was a man in his mid-70s. Fellow eye, similar finding. I have done almost a decade earlier. Everything went off fine. So I perform a hydro-free dissection. I don't believe in any hydro steps in post-polar cataract. Here I have made a triangle, a base is towards the nasal side, apex subincisionally, so you have a vertical wall. And it is because it is a harder cataract, so I want to start chopping from a deeper plane. Same strategy that was demonstrated in my previous case is being shown here with much, so the chopping happens very smoothly. Now, why I do not use a hydro steps here, even if you do hydro delineation, you can have an inadvertent hydro dissection that may rupture the PC. So I think that led on to the genesis of the inside out hydro delineation, just to avoid accidental hydro dissection while performing hydro delineation. Limited hydrodissection also doesn't make much sense, because how do you limit? I don't understand. So by separating the capsule, you basically break the cleavage in the adhesions. So the fluid sort of seeps through as you do phacoemulsification under the capsule and goes behind in a slow manner, so that the posterior capsule, so that there is the nucleus is mobilized. Now, as I remove the last chunk of the nucleus, I noticed that there is a small PC defect. I'm using hydroxypropyl methyl cellulose, and now I realize that I should not have done that. So I go with bimanual irrigation aspiration. The cortex is started removal from here. And here is again another thing that should not have happened, because the PC rent is located here, and I should have focused entirely on removing the cortex from this area, the area farthest from the PC rent area. And then the irrigation also should not have been brought here. This is a mid-70s gentleman, so his vitreous is also liquefied. Antravitreous face is not very condensed. So I had a PC rent, and then I injected HPMC again. And before I removed my handpiece from the other side port, injected triamcinolone acetonide 1:2 to dilution. Now I dilute a little bit more, because subsequently vitrectomy has to be performed, and you have no business to work within the anterior chamber with the vitreous strand being there. So a cutter, so I'm performing a bimanual limbal vitrectomy. And my initial plan was to use the same cutter, irrigation aspiration cutting mode, because I have a dual linear foot pedal machine with those features. So it is not happening well. So I decided to change my strategy. So instead of that, I injected OVD again into the anterior chamber and went for dry cortex aspiration. So that worked pretty well here. By this time, the PC rent has enlarged significantly. So now I go with my hydrodissection cannula, strip off the cortex from the fornices, bring it to the subincisional area, and then aspirate whatever is there. So the cortex is removed, working from the side port from the main incision. Before the intraocular lens goes in, again I stain the anterior chamber with triamcinolone acetonide, 40 milligram per ml, diluted 1:2. Compress the capsular bag in the periphery by injecting HPMC or whatever OVD you have. And then I use the 3-piece hydrophobic acrylic lens. The leading haptic goes into the sulcus. Make sure that it doesn't dive down through the PC rent. Then you will be dropping the lens in the posterior segment. So this has to be carefully done. The trailing haptic, again, I don't dial. I just compress and push it gently, tuck it gently under the iris. The lens is kept in a different meridian. And so afterwards, I will be achieving posterior button holding of the optic to the capsular axis. So sulcus is not a very stable place for a 13 millimeter lens, though better than 12.5. So once you lock the lens in place through the optic capture, it stays very stable in the postoperative period, rest of his life. So this patient has done extremely well. So this is the postoperative view. So friends, in conclusion, while dealing with post-polar cataract, we must ensure that the counseling is properly done. Patient must be aware that what are the potential complications, and the patient should also be informed that the surgery may be done in the second sitting if there is a drop nucleus, or if you don't have the standby intraocular lens, should you require a standby lens. Customize the surgical strategy and phaco-parameters depending upon the findings in the given case. No cortical cleaving hydrodissection, so I do hydro-free dissection. No hydrodelineation, no inside-out delineation, though it works well in many surgeons' hands. Maintain deep AC at all the time. All steps of the surgery must be adept with the anterior vitrectomy strategy, and you need to maintain a necessary IOL inventory. So this brings an end to my first talk. Do I have time for the second talk?
Yes, you have. Yes, please.
Okay. So am I on the screen? Can you hear me?
Yes,
Yeah,
I can.
right. So actually, this is part one of the talk on cataract surgery in eyes with uh, unhealthy endothelium. Sujata will be talking, completing the talk in part two. Thank you, Sujata, for that. So, we need to have, even if the corneal endothelium is not very clear, we need to have a pristine cornea on post-op day one. So you have to take certain steps in the preoperative period, intraoperatively, and the postoperatively. So I routinely perform a very thorough slit lamp biomicroscopy and examine the corneal endothelium on the zone of specular reflection. And there are certain predictive factors for post-op need for endothelial keratoplasty. So I'm not going into the details of that. So I always inform my patients that, at some point in time, you may require an endothelial keratoplasty, and the patient has to be informed before you take up the patient for surgery. I also perform a specular microscopy, and all these things are done. And many a time I have seen patients with pseudophakic bullous keratopathy in the fellow eye. And when I saw the patient on slit lamp, I realized that this was a patient with fuchs, and maybe the earlier surgeon hasn't done the proper corneal endothelial evaluation. So pachymetry is something which we again routinely have to do for all these patients. And there is a cutoff value for the pachymetry, 630, 640 microns. And here, these corneas are not very healthy. So I'm not a big fan of using a lot of orocan eye drops for them. Povidone iodine also tends to make these corneas a little hazy, and because you want total clarity. So I really depends upon the LOX2 jelly in these situations. You have to make sure that the povidone iodine is totally washed out of the eye. I mean, I use it very rigorously, and at the end of this, before it enters the eye, you must ensure that the entire povidone iodine would have been removed from the conjunctival sac. Some of these cases, I would do a scleral tunnel rather than a clear corneal incision. Use an appropriate OVD strategy. You see viscoat, Hilon 5, Hilon G, everything has to be there. And this step is dependent upon viscoat. And some surgeons also believe in using BSS plus, though I have never used BSS plus. Use a soft shell technique or the tri-soft shell technique, wherein you inject BSS under Hilon 5. And recently, I came across this paper, actually, May issue of JCRS. See, the anterior chamber maintenance are becoming very, very popular. And this is a study published from Egypt. It says that surgery with the OVDs deprives the endothelium preserving effect of the OVD. And so anterior chamber maintenance should not be used during phaco in patients with limited corneal endothelial reserve. Do a small rexis. Make sure that all your manipulations happen within the capsular rexis. The nucleus should not pop out of the capsular bag. All the manipulations should be endocapsular. So chopping definitely helps in this situation. And as regards the surgical technique, use a technique which works best in your hand. So if it is a direct chop technique, that's fine. If it is stop and chop, which you're very adept at, and it works well in your hand, that is fine. So make sure that you do not put the phaco energy to judicious use. I would rather be using torsional phaco in these kind of patients, because it is very easy to uh, uh, use high power in harder cataracts without damaging the intraocular structures. Avoid instrument touch. For example, here there was AC collapse and the instrument touched the endothelium. Nucleus shattered is something which can have disastrous effect if you're dealing with a patient with a borderline endothelium, because this ricochets on the endothelium, it damages the corneal endothelium. So make sure that we don't do that. Avoid a hydrophilic acrylic lens, because post-operatively, if these patients go for DSEK, or DMEK, when you inject air, these lenses may have opacification. So that hydrophobic acrylic lens is the lens of choice. Always aim for -1 to -1.5 diopter myopia, because a hyperopic refraction is seen in DSEK as well as the DMEK. So initially people thought the DMEK is going to be neutral as far as refraction is concerned. There's a postoperative hyperopic shift is seen. Patient with Fuchs dystrophy, a cornea guttata, I will not be using multifocal lens, because as such, the cornea guttata will reduce the contrast sensitivity because of scattering of light. And I don't want any additional loss of quality of vision in these advanced technology lenses. So friends, these are the indications for performing only phaco in Fuchs dystrophy, Pachy less than 640. I prefer to take them up before the nucleus is too hard, protect the corneal endothelium at all cost, and this thing should be, this kind of cases should be done by an experienced surgeon. These are some of my cases, and they do extremely well if you have taken the proper precautions and done a good surgery. Thank you very much for your kind attention.
Thank you very much, Dr. Arup. As always, excellent talk and a lot of take-home messages there. Any questions we'll take at the end of the session. And as a follow-up, I'm just going to change the sequence a little bit. I think because he's spoken about endothelium and how best to protect the endothelium, we'll request Dr. Sujata Mohan to talk about phacoemulsification with endothelial disease, where she's probably doing combined surgeries. She's the Associate Director of Rajan Eye Care in Chennai, and she is also the Director of the Rajan Eye Bank. She's a Senior Cataract Cornea Refractive Surgeon and also has interest in glaucoma. She has won many awards, especially the Nari Puraskar Award from the President of India, which is probably the highest civilian award for women, and has many presentations both in Indian conferences and Western conferences. So I will not waste much time and request her to make her presentation. Over to you, Dr. Sujata.
Yeah, can you see my...
Yes,
okay,
yes,
right.
yes.
So my topic is on management of complex cases with endothelial disease. And so since Arup has touched on all the more important factors of doing how to handle these patients, I'm just directly going to show you some case presentations. See, this case one is a 55-year-old female with bullous keratopathy secondary to Fuchs endothelial dystrophy. She had grade 2 nuclear sclerosis. So the plan was with the phaco with a DSEC. So you can see how loose the epithelium is, and it's coming off in just one sweep, just like a epitheliorhexis. And once you've removed the epithelium, your view is much better of to do cataract. So after removing the epithelium, you can be injected viscoelastic. And I'm going ahead with the temporal clear corneal phaco. As of now, I'm going to maintain the incision as a 2.8 millimeter incision till I finish the phaco. And once the phaco is over, for DSEC, I'll be extending incision. So the most important thing here when you're doing a combined procedure is do a smaller rhexis. Particularly like Arup also said, when there is an endothelial disease, if you want to do all the manipulations inside the bag, and if you're planning for a combined procedure also, it's better to keep a smaller rhexis because you don't want the IOL to pop out later on. So that is going to be a problem with the descemex, the graft in place. So after routine phacoemulsification and very meticulous cortical cleaning, it's very important. You don't want any inflammation post-operatively. Injecting an intraocular lens into the bag. And once that is done, we already have a viscoelastic in the chamber. So we have a very nicely formed chamber. So I'm just marking the center. I'm using a reverse Sinski to peel off the endothelium. This is a quite advanced case of Fuchs. That's why the whole epithelium was edematous. So you can see how nicely this whole epithelium peels off. If you have a dilated pupil, actually you can see better because of the retroillumination. And once the whole epithelium, you can get it in one go. There are cases which have been left far too late, and then you tend to get scarring. Then you'll get multiple pieces of the endothelium. Here you can see a very nice round endothelium, which is completely removed. And you go ahead and completely remove all the viscoelastic from the chamber, from underneath the lens. So now I'm doing a small peripheral iridotomy inferiorly, injecting air. And now the next, I've already prepared the graft. And I'm coating it with high density viscoelastic. And I'm just going to push, I have a push through technique. I'm using a glide and removing the top layer. And then I'm just using it's probably about 70 to 100 microns. I'm just doing a push through technique and gently remove the glide. The once glide comes out, then you can inject saline and unfold the graft. And then inject air. So it's very important that unless you have a very good tunnel, sometimes during this phase you can see that the graft is trying to come out. So it's important to keep a note of it. Here I'm using a Sinski to position it. You can just tap, 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 and then it automatically comes into position, and the surgery is over. So this is my first case. You can see the post-operative this thing. Second patient was a 65-year-old male, localized bullae secondary to Fuchs endothelial dystrophy. Again, underwent, you can see this is very localized, but still, I think because it was in the visual axis and the grade of the cataract was also quite advanced, we discussed the options with the patient and went ahead with the combined procedure. Here you can see that I'm staining the endothelium. See that the staining, I'm using a trypan blue to stain the capsule, and it's also going to stain the endothelium. So that gives us a very good glow. And here you can see again that my rhexis is quite small. It's about 5 millimeters. I don't want the lens to pop out in the post-operative period. The patient needs to be positioned well post-operatively, at least for 24 hours, to make sure the graft is in position. And if you make an inferior PA, the advantage is that you don't get a pupillary block. If the patient does have a pupillary block, you can ask the patient to sit up and the air bubble moves up. So it's a great advantage. And again, marking the center. Now here I've used an 8 millimeter trephine to mark the external position. And you can see again, beautifully the whole thing is peeling off, because these endothelium is quite fragile. They are already damaged endothelium. So it comes off quite easily just by using a reverse Sinski. It's very important when you're scoring the endothelium not to disturb the stroma, because if you disturb the stroma, then it's going to be a big problem. You will get some scarring, and you might have a problem during insertion and late dislocation and all that. So you just remove all the viscoelastic from underneath the lens as well as on top of the lens, do an inferior PI, and then you put the graft in position. So inject it and unfold it, inject air, and the procedure is over. So the next case I'm going to show you is a 60-year-old patient who underwent a phaco with a nucleus drop on the table. It was managed by pars plana vitrectomy and nucleus removal. The patient was left aphakic and referred here for aphakic bullous keratopathy. So this is the patient. So I'm preparing the eye to receive the glue, and I'm also going to do a combined procedure. So in this patient, what I have done is I'm first doing injecting the glued IOL. And after completing the glued IOL, what I'm planning to do is I'm going to do an SFT, that is to bring down the pupil. The pupil is fixed and dilated, so we don't want that. It's going to be difficult to do an endothelial keratoplasty like with a large pupil. Here I'm using an AC maintainer, because once when you're planning for a glue, you need some chamber stability. So I'm injecting the IOL. There are various options. You can use MA60 or you can use a Technis IOL, whichever you're comfortable with. And once it's done, I'm tucking this into the chariot's pockets. Yeah. So the next stage, once this is done, the next stage would be to do an iris suturing, that is SFT. SFT is done, it's a single pass 4-through pupilloplasty. So you take the 10-0 Prolene, dock it, you pull out a small loop of the Prolene suture, as you can see here, and then you just make 4 throws into it. So the advantage is you just need to just pull it on either side, and then you get a very nice knot. So here again, you can see one end is a 26 gauge needle, which is docked into it. The 10-0 polypropylene is pulled out, made it into a loop, and you can see that other end is being put 4 times through it, and you get a nice round pupil. Now I'm measuring the cornea to see what will be the size of the graft. Here again, I'm doing an endothelial scoring using the reverse Sinski. This is a little bit of a scarred cornea, as you can see. And these scarred corneas, you may not be able to get one single bit of endothelium. You might have to go in for several times and get multiple bits. So this is very, very important, particularly if you're planning for a DMEC, you just make sure that there is no endothelium remnant. Because it was a vitrectomized eye, eye is very soft, so I did a venting incision so that there won't be any late detachment of the graft. So now I'm pushing the graft inside and injecting air. So I've just put a pre-placed suture, and you can just keep tapping on the graft and it comes into position. So this is the end of the case. So these are some of the patients who have undergone DSEC. And if I have time, I have one very interesting case to show, an AC explantation with glued IOL in DMEC and pseudophakic bullous keratopathy. Patient has a AC IOL, a scarred cornea, and so you can see how scarred the endothelium is when we're trying to remove it. Once you remove the endothelium, you'll have a better view of what's going on inside. And so this is a little bit of a tricky thing, because when you're planning for a DMEC graft, it's important that you don't leave any bit of endothelium. That's very important, because you can go in for a graft dislocation. So then now this has been done, completely removed. Bits and pieces have come out. Now I'm removing the AC IOL. AC IOLs, they tend to form a cocoon around the periphery. So it's important you rotate them out, not to just pull them out like other intraocular lenses. So the tunnel is already ready, and I'm putting a glued IOL, rigid glued IOL. Actually, it's a foldable lens, but because it's a large tunnel, I'm just putting it and tucking into the chariot's pocket. So next step would be, I've sutured a part of the incision and I'm injecting the DMEC graft, which has been prepared already. The next step would be to just tap it. So the difficulty in this patient which I had was the eye was very soft, because patient has already undergone vitrectomy. And not only that, now because of the removal of the AC IOL and multiple the cornea had become very edematous, and I had quite a difficult time in visualizing the graft. So what I did, I thought I'll use an endo illuminator to see if I'm able to see the graft edge. And one portion of it, as you can see here, was a little bit folded up, but with repeated tapping and injection of air, you can see that is a folded area. We were able to unfold it and complete the graft. The one advantage I did was that I had stained the graft very well. So I was able, towards the end of the case, you can see that's a very well-centered graft, and the case was completed. So with these few surgeries, I'd like to thank Dr. Ashok Rangarajan for giving me this opportunity and for allowing me to show my cases. Thank you.
Thank you, Dr. Sujata. Excellent talk. Even I learned a lot. But then I just wanted to know, doesn't the corneal haze prevent you from, doesn't it prevent the visualization when you're doing the glued IOL?
Glued IOL, actually,
in the last surgery I was watching.
The last surgery, it is a little bit difficult, but not so bad. DMEC was a difficult part for me, because the graft is so thin. It's not like a DSEC graft where you can see it so easily. Fortunately, the one good thing was it was well stained, so I was able to make out. And the other thing was, this was done as one of my first few cases. So I had a very large graft. So that fold was not going away for some time. But ultimately, the patient did well. I was able to make it stick, and ultimately the patient did well.
Great. Thank you so much. Thank you. We'll take up some more questions towards the end. I'll now request Dr. Sagar Bhargav to come forward with his presentation. Dr. Sagar did his anterior segment fellowship from Shankar Nethralaya after doing his MS, and worked as a consultant in cataract and glaucoma and refractive surgery in Shankar Nethralaya, Chennai, and then he was in Shankar Nethralaya, Kolkata, after which he is now in a group practice in Netralayam and in BBI Foundation in Kolkata. He's a high volume cataract and refractive surgeon, and also does glaucoma. So over to you, Dr. Sagar, for your presentation.
Thank you very much, sir. Is my slide visible?
Yes, it is.
Yeah. At the outset, I thank Dr. Ashok for giving me this opportunity to be presenting in this August panel. And the topic that he gave me was cataract surgery in small eyes and post-RK eyes. Now, let's do a little revision as to understand what exactly is a small eye. And this was a paper which came in JCRS 2015, and very nicely schematically it has shown that how different types of small eyes are there. And what we essentially understand is microphthalmos is basically a symmetrically small eye, and it's basically the axial length is less than 2 standard deviations of what it should be. And when we talk about nano-ophthalmos, it's basically a small eye with thickened sclera. As we can see here, white portion is quite thick. And then there is something called as relative anterior microphthalmos, where the axial length is actually normal, but you have a crowded anterior chamber. So small eyes are something which all of us face on a day-to-day basis. and they do come for in surgery. As a practicing glaucoma surgeon, I do get these cases quite a bit, and even in general practice, you will get it. So first thing, you need to basically differentiate it from a condition differentiate it into different parts. So when we talk about relative anterior microphthalmos, we have to, as we discussed, that axial length should be more than 20 millimeters. The horizontal corneal diameter is around 11 or less. Most important is anterior chamber depth is less than 2.2, and patient should not have any ocular malformation. Now let's look as to what happens in nanophthalmos. So nanophthalmos is a condition where patient's axial length usually is below 20.5. The retinochoroidal scleral thickness is more than 1.7 millimeters, and there is no ocular malformation. And what we call it as lens axial ratio, which is basically the lens thickness by the axial length of the eye, should be more than 0.2. So if these criteria are met, your patient becomes a nanophthalmos, and your treatment radically changes. So this differentiation is very important before you approach these patients. And then there is another subset, which is essentially just a small eye without having all these issues. So axial length of around 21, borderline narrow, but those can be treated in a different way. Now, most of these small eyes, very important that you should do a gonioscopy, because if there is an angle closure, you need to basically do YAG-PI for these patients, because even during a standard phacoemulsification, you can face with a condition called as aqueous misdirection. This is very important if you're dealing with nanophthalmos, because studies have clearly shown that if YAG-PI is done before development of peripheral anti-synecdoche, the chances that the patient will need medication becomes very, very less. So this has prognostic importance. So YAG-PI is something that one has to remember in mind. Now let's go on to a case. So Dr. Ashok asked me to present a case on relative anterior microphthalmos. So I will be presenting a case very similar to that. So this was a 48-year-old gentleman who had undergone vitrectomy with silicone oil for a retinal vasculitis with TRD. The retinal surgeon didn't want the oil to come out. So basically, patient had a total cataract. So we had to remove the cataract with the oil in situ. So these were the parameters of the patient. Axial length was around 21.97. Anterior chamber depth was 2.15. So very, very shallow anterior chamber with a lens thickness of almost 5.82, which was a total cataract. And according to the A scan biometry, we were getting around 26 for as an emmetropic value. We chose 32 diopters because there was oil in situ. So very important to plan what viscoelastic you will use, because we have a space constraint there and we need to protect the corneal endothelium. So a combination OVD like Viscovisc is something that can be used, which one viscoelastic itself serves both the purpose, or a lot of times this may not be available, then you can go in for a soft shell technique wherein you use a combination of Hilon 5 with Viscode. But and if you are using Hilon 5, one has to remember that the parameters have to be low flow, because only in low flow parameters Hilon 5 stays. Now let's move on to the case. So you can see the case. This is a pupil which has basically bound down to the cataract. So what we are doing is, under the saline injection, we are trying to basically release the posterior synecdoche from both the sides. I have not stained the capsule as yet, because I know that the stain will not go beyond that. So I'm using the saline to release the posterior synecdoche, so that the tryptophan blue nicely goes to that. So now we have stained the capsule, and now most of these cases will have smaller pupils. So iris becomes mandatory in these cases. You should never do surgeries in these eyes, thinking that you will manage. It's always better to have good exposure. In this, we are having a little smaller pupil capsular excess size, so we will deal with it later on. So as we can see that this is a direct chop, horizontal chop with a Chang's chopper. And now slowly we are basically creating small pieces out of it. And one thing very important to remember is that you have to keep your phaco-tip in the center. Don't allow the pieces to come in the anterior chamber, because that's where they will hit the endothelium and cause all the damage. So essentially, you're keeping everything there and let the fluidics do its work, and slowly and steadily till the last piece, you basically keep it there and everything will fall in place. So now we see that the capsular opening is small, and we are going to put a 32 diopter lens. So we just basically do a small lick and enlarge this anterior capsular opening using maculocapsular excess forceps. And finally, after adequate capsule opening, we are able to put the lens in situ in the back. So this patient ultimately did well, though did not get it visually, but there was no complication in the post-op period. Let's move on to another case scenario. Here's a 71-year-old gentleman, had a YAG-PI done both eyes, was on Timolette, had cataract changes in both eyes, and This is what the parameters look like. He had a sclerocorneal thickness of 1.9, axial length was 19.27, IOL power was suggested around 38 to 41, and anti-chamber depth was 2.3. So obviously we are dealing here with the case of nano-ophthalmos. With nano-ophthalmos, one has to remember that we have a higher risk of complication intraoperatively. Can be posterior capsular rent, aqueous misdirection, or you can have intraoperative or post-op uveal effusion, or very rarely suprachoroidal hemorrhage. Now, once a PCR happens in these cases, remember that lens that we are going to implant is a single-piece lens, which cannot be which cannot be put in, and you don't have a choice of putting a 3-piece lens here because that range is not available. Now, let's look at the case as to how did we manage this case. So as we can see here, we are going to do a technique called as sclerotomy, and this is basically we are hooking the inferior rectus and the medial rectus. We are going to do this in the inferior nasal quadrant. So first, this is a single quadrant sclerotomy that we are doing. 2 millimeter marking is done from the limbus, and then 4 millimeter scleral marking is done, where we basically fashion out by 4 by 4 millimeter scleral flap there. So once the flap is created, about 4 millimeters from the limbus, you essentially create a small block of deep scleral tissue, and you essentially create a window in the suprachoroidal space for any uveal effusion to happen that will keep leaking from there, and it will prevent collection of fluid. So in this scenario, we have sutured it, and now we move on to the surgery. And the surgery, again, it's difficult because you don't have space there, so you have to use all the viscoelastics that we discussed and move on to the course. Here, very important thing to remember is that when you are doing side entries and the main entry, these eyes tend to have a little thicker cornea, especially in the periphery. So your standard angulations, you have to be careful, otherwise you might end up with a longer tunnel. So here that point has to be remembered, and here we are making the clear corneal incision, and we are proceeding. Again, this point also is very important because we don't have too much space there, so you don't want to do a very, very vigorous hydrodissection. So it should be a very gentle hydrodissection, just enough for the nucleus to rotate. And here we are using a direct chop again and taking care of the nucleus. So this patient, we had to use a 40 diopter IOL. And the thicker IOLs are slightly difficult to handle because they come out with a thud. So be prepared for that. At the end, you will have a small thud when it comes out. It typically happens because of this thickness of the lens. So now the lens is in C2. We have sutured the main wound, and this was the post-op outcome, and the patient did very well without thinking. Now let's move on to the next spectrum. You have this gentleman who had basically YAG-PI done and has cataract, but look at the axial length. Now it's almost in the range around 15 with a thick sclera. So here we are dealing with a very severe form of nano-ophthalmos. So we basically here employ a technique called as anterior lamellar sclerotomy, as described by Dr. Martin Wax. And here we essentially do a lamellar sclerotomy where we remove the scleral roof and do a V-shaped sclerotomy. Let's see how it is done. So I will just straight away show you the sclerotomy. And we basically 2 millimeters, 4 millimeters from the limbus, the V-shaped incision is made, and you lift the apex of this V. So you can see how thick is the sclera. We have already re-roofed the sclera there. This you just do it in this case, I had done it in 4 quadrants. You can do it in 1 quadrant or 2 quadrants, but nowadays people recommend mainly with the inferior 2 quadrants. So here I'm basically de-roofing the other quadrant, and we again do the same thing. So basically you are removing the apex and leaving a small area of this thing, exposed suprachoroidal space. So again, this case also had a small pupil as expected, and you do the surgery with the standard principles. This was the patient's recovery, and patient had an uneventful recovery. Now, this was the patient who I've been following up for almost 10 years now, and this is the eye of that patient. Unfortunately, the other eye had a SICS done elsewhere, and this eye lens was put in sulcus, and lens now has partly come out and has caused corneal decompensation in this patient. So one of the take-home points for this is that in nano-ophthalmic eyes, never do SICS. It has been proven by an RCT done by Arvind Eye Hospital, and you have to do an in-the-back placement of the IOL because these eyes tend to do well in the long run. So to sum up, these eyes have higher risk of angle closure. Do a YAG-PI if you are in the early stage of cataract. You have to do a pre-op mannitol to reduce their IOPs. reduce the chance, you have to reduce chances of uveal effusion by doing sclerectomy, or if required, a spherectomy also. And cornea, remember, it's thicker in the periphery, so entry wound has to be taken care of. ACD, if it is less than 2.3, again proven by paper, there is a high chance of endothelial damage. And very important, you have to avoid interchamber collapse at all points. And vitreous tap, one has to be careful because there is a very high tendency to do vitreous tap to give more thing. But these pars planas are little displaced forwards, and they can be actually smaller than what you think. So one has to be careful in that regard. So I just have one case on posterior on RK. Time, sir?
Yeah, please go ahead. Please go ahead. We have time. We have time.
So basically now we'll just discuss about post-RK scenarios. Again, a very challenging condition, because when you have so many RK marks on the cornea, you tend to get intimidated. Here, the main challenge is to get the IOL power calculation correct. Of course, that's beyond the purview of this talk. But what is important is that you can have variable intra-op pores with RK patients. I'll just show you a very standard RK case where you can see this is a 20 cut RK. And my way of doing it, and what is described most of the literature, is to do a scleral tunnel. So we are basically doing a temporal scleral tunnel. And here, the second important point is when you're doing site entry, you have to make sure that you're not hitting the incisions. Otherwise, they can start leaking. Otherwise, one has to remember that these eyes are myopic eyes, because that's the reason why they have undergone RK. So when you're doing phacoemulsification in these patients, you have to essentially use the same precautions that you would do for any high myopic patient. That means lower bottle height, fluidics should be controlled. There should not be too much of anterior chamber fluctuation. So here we have done the anterior chamber entry, and again the phacoemulsification is done with the standard way. So there's nothing different in the surgery as such, but you have to be watchful on this RK incision so that they don't give away in the during the surgery. At the end, it's always a good idea to suture these wounds, because the sclera has low rigidity. There are chances that it may be unstable, so it's better to suture them. I'll show you a next case, which is a little more difficult. So this was a patient who was a one-eyed patient. Other eye lost due to RD, and patient had RK 25 years back with just hand movement vision. And this was the picture of the patient. So a dense scar in the center with around 20 cut RK. Now, how do we handle this? We thought, let's do a phaco first and later on decide about the cornea. So we did the calculation, and the lens power that came out was around -8. Now let's look at the case. So we go ahead with, So we go ahead with the case.
It's not moving.
His connection is lost.
Sorry, yes, it's got stuck.
Yeah.
Okay, I think it's no problem. Take your time.
Yeah, is my screen visible now?
Yes, yes, it is.
So the challenge in this case was basically to get the rhexis correct. So rhexis was the main difficulty in this case. And we, with the tilt of the globe and with the variable globe, we were able to get the rhexis done. And here we are completing the rhexis. And again, we are making a scleral incision here. And the second challenge was to get the chop right. So here, again, the Chang chopper came to our rescue. So what happens is basically you feel the nucleus with the help of this blunt end of the Chang chopper, which is a curved end, and you basically try to get the first chop. Once the first chop is done, then things fall in place, and slowly and steadily you can basically debuild the nucleus and remove the nucleus pieces one by one. And as the surgery progresses, we can see that we are able to take care of the nucleus, and finally, at one point, once the nucleus are, we found that one of the RK incisions started leaking. So keep the suture handy, suture, and give an interrupted suture. And in this case, we also put an ECR because axial length was very high, and we did notice some amount of zonal weakening here. So we did put a CTR there, and here we are putting -8 diopter hydrophobic acrylic IOL in the bag. And finally, this is how it looked at the end of the suture. Again, one or two incisions also again opened up. So make sure that all the incisions are closed before you patch the eye. And I've sutured here the side port also and the main port also. So this patient actually achieved ambulatory vision after the surgery. His vision was around 2/60. And this is how the pre-op and post-op looked, and he has become mobile now. So I would just sum up that in RK patients, scleral incision is something that helps. A lower bottle height is what you would like to do, and watch out for these RK leaks, and always suture the main wound, and sometimes require side port entry also. Thank you very much. I'm sorry about the last video glitch.
No problem. Yeah, thank you so much, Dr. Sagar. Wonderful videos and wonderful talk. I'll now request Dr. Meenu Mathan. He's a consultant cataract surgeon from Chaitanya Eye Hospital in Trivandrum. Has had his post-graduation and training from Aravind Eye Hospital, Madurai. Again, a very experienced cataract surgeon in all forms of cataract surgery, small incision, manual small incision, phaco, femtosecond, and is a chief instructor in many courses in ASCRS and in our All India conferences. So over to you, Dr. Meenu.
Thank you, Dr. Ashok, for this opportunity. So I would talk on phacoemulsification in subluxated cataracts and small pupils. So one thing we should know about is using capsule stabilizing devices. So I would take you to capsule tension ring first. So is my sound okay, Ashok? Is my sound okay, or is there any lag?
There was a little lag. I don't know if it's to do with the connectivity.
Okay, now that was maybe because of the. Now it is okay.
Yeah, now it's fine. Clear. No, it's breaking again. The voice is breaking.
To inject the
we are not able to hear me, no?
ring.
Not good.
I usually make a comparison. This is opposite.
Meenu, we are not able to hear.
To hear you.
सर आप अपना वीडियो कैमरा ऑफ करके
Video is also not moving.
वीडियो ऑफ कर लीजिए, आप अपना नेटवर्क लो है.
He's coming back, is it?
I'm hoping, yes. I'm trying to get across to him.
So we don't have any other presentation, right?
This is the last. Yes.
I think, yes, we should wait. So by the time if the sir is coming back, why don't we have some exchange of questions or something?
Yes. So no, I just have one. Let me make the beginning. To Dr. Sagar, I was wondering, Sagar, would you have done a PK with a cataract in that patient? Or I mean,
that would have been a good option, no doubt, but he was not in a mental state to have such a complicated surgery. His only concern was that it should be just be ambulatory as of now. So we did discuss with him this issue. He said, let me have the cataract surgery first. Let me see how ambulatory I become. And after that, I can always take a call. So what I realized is that on slit lamp with the retro elimination, I was able to see the cataract quite well. So I thought it's a doable surgery. So that's why I took it with a nice retro elimination.
And just one more question, Dr. Sagar, regarding your side port incisions that you made. Do you make a special choice of where you're putting the incisions? I noticed that you put it in between the two incisions, that archy incisions. But there's always a risk that it can extend and open out the incisions. Do you have? I mean, have you considered doing a little bit more scleral or near?
Yeah. I've done 24 cut archy also. So in those cases, I go a little posterior. Now going little posterior again is a two-edged sword thing, because you can start getting iris prolapse there. That's the big problem. So I try to do it in 20 cut in between the two things and see with minimal possible entry if I can able to manage. So, but I agree with you. In 24 cut and in a higher cut, it is difficult. Yes.
Very well done surgery.
Can you see mine now?
Yeah.
Yes.
Clear.
Okay, sorry, very sorry about that. Somehow it got cut. So, capsular tension ring. We'll continue with this.
Sorry to interrupt you.
Go through the
सर आप
patterns
अपना
and
वीडियो कैमरा ऑफ कर
just
लीजिए.
make sure that the leading eyelid goes. Last time I tried to switch off my video camera and the whole thing got disconnected.
No, now the
Stop
voice
video.
is clear.
Okay, I think I'll just keep it on like that. Otherwise, everything will get cut off.
No, now it's clear.
Okay.
To switch off. To switch off other people's video camera, it will be better.
That's what I'm trying to do. On my video, mute is there. Okay, that's gone now.
Yeah, there you go. You're fine.
Fine. Okay, so the paracentesis, if you can notice, the pressure of pushing the CTR is at the edge of the paracentesis. That is another crucial point, so that it moves smoothly into the capsular bag. And the tip should not press against the equator. That is one point which we need to make sure. And once it travels, we can use a second instrument through another paracentesis to guide the trailing eyelet, or we can use a microrhexis forceps through the same paracentesis here and get the trailing haptic directly into the capsular bag. So we should make sure that the lens CTR has gone into the capsular bag. So once the capsular bag is fixed, so here the first thing I do is to identify that there is no vitreous here. So if there is vitreous, we got to do a limited vitrectomy so that the AC is clear of vitreous. But then if you do too much of vitrectomy, the lens will become more unstable. There won't be much support. So vitreous should be there to support your lens. And then I put viscoat. Viscoat is the one which will plug that area, no financial interest in that. And then put HPMC or even cohesive viscoelastic if you want over it. And after that you do a rhexis which is centered to the bag. And then I use iris hooks. I like iris hooks. Capsular hooks can also be used to support the bag. And then this is the way you put it in through the main incision also. It's possible. And after that, we use low parameters. So bottle height, not to have surge, and your irrigation and aspiration and vacuum all should be low. So that slow motion phaco happens here, and enough energy for the particular nucleus which you are doing. No point in reducing your energy too much, because you have to cut the nucleus which is has to be cut without difficulty. So the technique, we can use the same technique. I use my same regular technique like initial burrow and then chop. And we realize that even after hydrodissection, the initial rotation will be slightly difficult because some areas of zonules are not there. So it has to be very gently done, and make sure you irrigate, you hydrodissect well, and then rotate well. Once the nucleus is emulsified, the main point is not to shallow the chamber. Do not take out the irrigation, fill the bag, and then take out the irrigation. IA is difficult with the CTR in, because it can trap the cortex between the capsular tension ring and the equator, but then it can be accomplished slowly and by tangentially pulling, not directly pulling towards the center of the lens. So you can place a single piece IOL in the bag, or a 3-piece IOL in the sulcus, and capture it onto the rhexis margin. So femtosecond laser in subluxation is very useful, because see, notice the rhexis can be positioned away from the area of the dialysis. If you can notice here, the dialysis on this side and the rexus is eccentric. The lens is now placed centered to the bag, and so that you have anterior capsule enough here to later support it with the hooks, or the IOL placement can be easier if you locate the rexus little away from the area of sound dialysis. So here it's a long-standing dialysis, very soft cataract. I proceed without a CTR first because the bag is very stable, no vitreous inside, very soft cataract. It's prolapsed into the anterior chamber first, and the whole procedure is completed. Towards the end of the procedure, after cortex aspiration, I can inject a capsule tension ring into the bag, and now I see some folds here, which I thought initially was a capsule tear, but actually it was just tension lines and also a fibrotic band which was behind the PC because of the long-standing trauma and the capsule fibrosis and the case ends well. CTR, as we know, initially you can place, but you can delay it also. You see, in such a case where the whole bag is very wobbly, so you touch the lens, it moves in all directions. So here, initially itself, if you try to place a CTR, especially when the nucleus is harder, it may be quite difficult and it may damage more zonules. So here, after a rexus, very difficult it is to do a rexus, but then sometimes you may need a bimanual technique to do a rexus. And after that, I support the bag with hooks. So iris hooks works very well for me, so I use only iris hooks. There are capsule hooks which can even extend up to the equator and support. And then after cortex removal, I get the CTR inside. Sometimes cortex removal will be difficult because the bag may move towards, along with the cortex, the bag may be moving. And at that point, you can even place an IOL and stabilize the bag, or at some point, you can have the capsule tension ring inside and aspirate it very gently. So when there are subluxations more than 180 degrees, and if you think that it's a progressive subluxation, you use scleral fixated fixation devices along with the CTR. Here it's a CONE modified ring. So here there's a very subluxated lens, and it's the rexus is being held with the hooks now, and the CTR goes inside, and there is an eyelet and a hook which is at an elevated level, and that is retained above the rexus margin. The ring goes into the bag, and this remains above the rexus margin, and it's rotated into the area where there is maximum subluxation, which is here. And before introducing this, the eyelet is threaded with the 90 proline. I have not used Gore-Tex till now because Gore-Tex is the one which will remain for life. And once that is done, these two needles which are outside the incision, I am taking out through a paracentesis which is opposite here. This is for convenience. And just like the scleral fixation, the needle is passed under the flap and the needle is taken out above the capsule. And then these two needles of thread of the 90 proline is threaded out, and the eyelet is tightened. You don't pull too much, it is just to center the bag, and then the suture is tightened onto the scleral bed. And there are segments also available. These are much easier to implant. The other one was quite difficult to implant, and so I don't use them anymore. I use only segments, Ahmed segments. Here it's a gross subluxation, very long standing one, and after the lens removal, I place in a capsule tension ring and see whether the bag is getting centered. The bag was relatively okay centered, so I then see whether the IOL will be centered. But after placing the IOL in the bag, the whole bag IOL complex is definitely decentered and is not well centered. So I create a flap here. You can do away with the flap. You can do a Hoffman's pocket without dissecting the flap or the conjunctiva. So this is about 1/3 of the ring, and with the eyelet and the hook, which is similar to the one on the ring. And the 90 proline is threaded into the eyelet, which is there on the segment. And this is made, I buy it from Orolab, no financial interest in that. And the segment goes, already there is a ring inside, and the segment is again positioned into the bag where there is maximum subluxation, and this eyelet remains over the rexus margin. And after that, like we saw before, the two needles are railroaded through the 26 gauge needle, which is taken above the bag. That is very important. Both of them have to come above the bag, and the sutures are tightened so that the bag gets centered well, and the flap is also closed, and you can see that the lens gets well centered with the eyelet being hooked with the thread here. So we move on to the next topic of small pupil. There are enough techniques of not using any dilating devices, I'm not going into that. So if you're comfortable doing a 4mm pupil, if you can do a Rexis 4.5, then if you want to continue, please do continue. But if you're not comfortable, if you cannot do a 4.5mm Rexis, I would prefer to use dilating devices. So iris hooks are very commonly used. Nothing should be against iris hooks, because we should realize that these incisions are very small. See, the type of the hooks which you buy also matters. But then I don't have any financial interest. Alcon used to make very, very thin ones. They have stopped making it now. So Oralab now makes, which is similar to that. It goes in through very small incision. You don't have to make it very large. See, don't let the paracentesis go. This is a 26 gauge needle. You make an incision with the 26 gauge needle there, and I'm just comparing the other incision here with the 26 gauge. It doesn't go inside, so that is smaller than that, but your ring, the hook goes in through that. So don't hesitate to make incisions for this. They will close by themselves, and there's no problem at all. Here is one case, post trab and a small pupil with this fibrous membrane at the pupillary margin. So release most of these fibrous membranes and the posterior syncytia. Once you release this, the pupil becomes more free. Otherwise, they tend to tear more when you try to stretch them. See, they move it in the direction very atraumatically. Don't pull too hard towards the center. Otherwise, sometimes it can cause even iododialysis. But then in a tangential manner, if you pull gently, it comes off fully, and then you get a very free this one. So again, I prefer to use 5 or even 4 with one sub-incisional. So, and you can notice the stretch between two hooks are much lesser if you use 5. And sub-incisional again helps in preventing dragging of the iris when you are introducing the phaco probe and all those. And here again, it's not pulled towards the angle, still the angle. See, it's just a 6mm opening, so that you can completely do your technique. So it need not be completely pulled towards the angle. That is what is most important. And the incision should be made as a stab incision and not going through the cornea 1mm and then entering. Then you will pull up the iris too much, and you can crowd the anterior chamber. And also the incision must be close to the limbus. And if you are cutting through the conjunctiva, then sometimes it will leak and it can balloon up the conjunctiva, and you can have fluid collecting within your area and over the cornea, and it can cause difficulty in visualization. If you cut through conjunctiva while placing the hook, please do a snip on the conjunctiva so that the fluid doesn't collect subconjunctivally. Here I am showing you a Malugin ring. So here posterior syncytia is released and visco is placed under the iris. That is very important. So then 2.2, it goes in through a 2.2. The leading scroll is engaged in the pupillary margin, and you can place this towards the side and tilt and engage two of these also in the first shot. May not happen all the time. And the fourth one can be left there. Need not push it too hard. Just pull the iris towards you and then engage. So you can get a 6mm opening. And after you finish your regular phaco, you can release one scroll, and the rest can be pulled out very gently, and they can be pulled out just with the forceps, or if you want to reuse, you can ETO it and reuse once. Or I have used it twice, and the second time it broke at the connection. There is a connection. If you notice here, this is the area where these two ends are connected, and if you open close 2-3 times, it is made to break, so that it is not reused. So it is not free of complications also. It has a learning curve. So, see, when you do it on a 2mm pupil, please do stretch the pupil a little bit and make it 2.53 mm, then try to implant any ring. So here you can notice that it is difficult to engage the side scrolls because the pupil is not big enough. So we are made to leave the whole thing free in the anterior chamber. That's okay. But then here, see, this is the original version where it was difficult to sometimes release off this hook. The injector has now been modified. The 2.0 has come, and they are more easy to release it. And sometimes it gets so stuck that you need a second instrument to release the trailing scroll from the injector. And once that is done, we can use either a forceps or a hook, Kugelen's hook, or a blunt one to engage the scrolls. Because the pupil is so small, we will be focusing on the scroll and the pupillary margin. We may skip the focus on the anterior capsule, and you may touch on the anterior capsule. You can have capsule tear because of the sharp Synski which you may be using. So I tend to use a Kugelen's hook with blunt edges, and again, as I showed you last time, lift up the hook, the ring, and then pull the iris back and then engage the trailing, the fourth scroll. And after that, while releasing also, please make sure that you pull on the scroll alone, not to engage on the iris also and pull. Sometimes you can engage on the iris also and pull, and you can get an iridiolysis when trying to disengage these scrolls. So coming on to the last one, this is the BHEX pupil expander, our own Indian one, Suven Bhattacharya's one. This is a very useful, very user-friendly one. And I'll show you, this is an IFIS case. So you may think that why would you need, this is a 4mm pupil, you can always tend to do it without that. But then I'm sure that it is going to come down in size during the procedure, and that's why I put iris hooks in the beginning itself in all IFIS cases. Iris hooks or rings. And this is the not the latest version, this is one version previous to the latest one. That's why it doesn't have 3 of those rings. But then alternate flanges are tucked underneath the pupillary margin. And once that is done, you use a forceps. Now we don't recommend for Sinskey hooks or the manipulator. Please use flat tipped. This is not the one which is regularly used for the ring, which comes with the ring. It's a sharp tipped one. Don't use this. Flat tipped ones have to be used, and holding it from paracentesis, make 2 paracentesis and put the visco underneath the iris as in all rings, and then engage it. And here again, if you have noticed, I have touched the anterior capsule with the Sinskey because I was using Sinskey there. So all the flanges, please engage with forceps, and that is the easiest one to do. You can, this is a 5.5, this looks smaller, but 5.5 which does not come down during your surgery is what is required, and that will give you the confidence to complete the whole case without any problem. At the end of the surgery, you can implant the IOL, but while implanting the IOL, make sure that the leading haptic goes into the bag and the IOL optic also goes into the bag, and the trailing haptic clears the ring. That is very, very crucial. Don't place it over the ring and try to dial. Sometimes you can involve the ring also when you are dialing it. And once one flange is disengaged, you can pull it out. It even comes through a 1mm opening. And that's it. Thank you very much.
Thank you very much, Dr. Meenu. Excellent videos and presentation as always. If I can, any comments or questions, Dr. Sujata, Dr. Sagar, anybody? Any?
Presentation, very complex cases. And
No. The only thing I have seen, Meenu, is when I've used iris hooks on the capsule to support, I have torn and burnt my fingers, the capsular edge. So nowadays I very religiously use the capsule hooks for supporting the capsular edges.
Now, what I have noticed is that Indian ones, the ones which we get it from India, the tips seem to be quite irregular.
Yes, they are.
You know, so that is one reason why you will get rexus margin tears. So if you use this, the ones which I was telling, the Oralab ones are relatively very smooth, but the Grishaber was much smoother. So
yes. Yeah, probably something to do with the tip quality. And similarly, I don't know, I was quite comfortable with the 3 hooks also, 1 subincisional and 2, you know, on either side. So you get a triangular opening. So I was very surprised to see that you were using 5.
I prefer 5 only in cases where the pupillary margin is very rigid, and you when you stretch, you will definitely get multiple tears. When you get multiple tears, if you have 5, the tension between 2 hooks are much less than the tension between the 2 hooks in if you place 3.
Great. Good. So I think we are on time, and thank you all very much for this wonderful.
We have 5 minutes more, I think. You know, don't we have 5 minutes more?
7:55 is what is said.
Yeah, we can 7:55. 7:50 only now. We can have discussion. Let's discuss. Okay, Sagar was very fantastic. Sagar's video was very fantastic. And small eyes, we think that they're easy to do, but then, as you said, without putting hooks, don't start off with that kind of small eyes if the pupil is smaller. And also use endothelial protecting devices very lavishly. The endothelial, as Dr. Sujata was showing, endothelial decompensation is much costlier than the surgery for that is much costlier than a viscoat, 1 or 2 viscoats which you use. You know, so
yeah. Yes, those were.
And I have a question to Dr. Sagar. What you showed was you had prepared the bed for in case of posterior sclerostomy. Am I right?
Yeah. So the second case which I showed, I had done 4 sclerectomies actually. So 4-quadrant sclerectomy I had done for this extreme narrowophthalmic eye. And you will be surprised to note that in spite of 4 sclerectomy, this patient had a choroidal effusion which lasted for almost 4 weeks. So that was the thing. Even after doing 4 sclerectomy, this surgery took me about 1.5 hours.
What was the axial length for that patient?
15.6. 15.6. And it was and 2 years down the line, I had to do the other eye also. So it was quite
which
tough.
lens gives 40? Which company supplies 40?
Right now, Alcon gives it.
AIOC also custom makes this.
Yeah.
And
so
do
Alcon,
you? Yeah.
No. Alcon has the standard platform, the
40,
single piece platform which comes at 40.
Do you suggest an intra on the table indirect ophthalmoscopy before you close in these kind of cases?
See, if you're doing a sclerectomy or a sclerotomy, it doesn't matter at all, because anyway, whatever the fluid is there will get drained over a period of time. You're only worried about a suprachoroidal hemorrhage, which anyway, if it happens, you will get that clue when you're operating itself. So indirect probably may not have too much of a role when you're doing it. Any thoughts on that? Any experience like that you had to do?
No, I was just asking because you said that they had an effusion, and whether you could see that effusion.
No.
Post-op period.
Post-op period. Post-op period. It took a while for it to settle down, but eventually it settled down.
So when you had a post-op effusion, did you go through the same sclerostomy site and try to remove?
No. In fact, this has been noted in various papers. You really don't have to do anything to these effusions. They usually are self-resolving over a period of time because you have already created the opening. And nowadays, the recommendation is that you basically just need 2 inferior openings because of the gravity, the fluid kind of drains from there. And people do only scratch marks now. Marks, and they use a punch to just widen one of the edges of the scratch mark. But I find the technique which was this,
Alternatively, you can even use a 26 gauge needle just to puncture it. You don't have to really go and make a flap and all that. That's why normally.
No. The problem is not that. Problem is you're not going to remove it completely with the 26 gauge. You need it to continuously drain. That is the problem because the pathology is different here.
So there are people who make this cuts, but then cauterize the edges of the sclera, so that they remain open.
Exactly,
and then you sweep a little bit of cyclodylus spatula underneath this, so that it creates some space, and then it leaks, and cover it with conjunctive.
Yeah. In fact, we do this for the post-trap choroidal drainage. Exactly the same principle. But for a nanophthalmic guy, you have to be a little more bolder because they are very difficult to treat. They are very difficult.
Was your partial thickness flap trying to cover the deeper sclerectomy?
Yeah. So there are 2 schools of thoughts. So partial, you make one is that you keep the flap and cover that thing. The other is you remove the flap. So that's a sclerectomy. So the ones which are very advanced, sclerectomy is what is recommended. But most of the people now just kind of keep one because they don't want to expose the uveal tissue.
Correct.
Because of the intraocular. Yeah. So off late, I'm keeping the flap. But I'm loosely sutured.
Suture. Do you suture it?
Yeah.
Yes. I loosely suture it. Yes. I suture
something like a trap flap. That's
exactly. And when you actually do it, you can feel that sclera is so thick that you think that you have reached the depth, but it takes a little effort to actually reach the suprachoroidal space in this nanophthalmic eye.
Boldness is what you have specified. That is the word to use. Boldness.
So now may I request Dr. Ashok Rangarajan to summarize the conversation today?
So I think all different scenarios we have all seen, and excellent talks by everybody. I hope this is available for others to view later on also, so that more people can benefit from these talks and discussions. Thank you all very much, Dr. Sujata, Dr. Sagar, Dr. Meenu. I think Dr. Arup has gone to the other session. So thank you all, and hope to have another session in the near future.
So before
thank you, Ashok.